Hello and welcome again to the continuation of the 5th Pancreas Cancer Academy organized by the Central European Cooperative Oncology Group. I want to thank the faculty which participates in this 5th Pancreas Cancer Academy. I want to thank Xavier for supporting it and thank Gerard Prager for organizing the faculty and coordinating the news that are being brought to you. I wish you very interesting hours with the continuation of the Pancreas Cancer Academy, and I do hope that we will see each other in person in the very near future to celebrate the 6th Pancreas Cancer Academy. Thank you very much and all the best.
Hello, my name is Gerard Prager. It's my honor and pleasure to introduce you the speakers of this symposium today. The topic of this symposium is oligometastatic disease in pancreatic cancer. And we have a very designated speaker, Professor Thomas Seufferlein, who is the head of the Department of Medicine at the University of Ulm. He's an expert in treatment of pancreatic cancer as for other GI cancers. We have as discussions today Dr. Uesaka from Japan. Very welcome. He is the chief of the Division of Hepatobiliary Pancreatic Surgery in Shizuoka, Japan, and the director of the Shizuoka Cancer Center Hospital. So very welcome as well. The second discussant is Professor Falconi. He's a full professor of surgery and the chairman of the pancreatic unit at the University Vita e Salute San Raffaele Hospital in Milan. And he studied medicine in the University of Verona, and he was also traveling and had medical research projects in Germany, and he is now a member of many medical societies, including the IAP, EPC, ENETS, and many others. Professor Falconi is also an executive committee member of ENETS and IAP. So everybody welcome, and I would like to start with Professor Seufferlein, who will give us today the scientific background about oligometastatic disease and whether it's worth considering those patients also for secondary resection. Thomas, please.
Dear colleagues, it's my great pleasure to welcome you to another CCOG Discussion 2021. Unfortunately, we cannot meet in person, but at least we can discuss here online via the internet. My name is Thomas Seufferlein. I'm the director of the Department of Internal Medicine 1, and my research interests are mainly GI cancer and with a particular focus on pancreatic cancer. And therefore, it's really my great pleasure to lead this session today on oligometastatic pancreatic cancer. This is my conflict of interest statement. When we talk about oligometastatic disease in pancreatic cancer, there are several questions arising. First of all, is there a target group with oligometastatic disease in pancreatic cancer at all? And if so, is there a good definition of this target group? And given that there is a target group and there is an appropriate definition, does it have any consequence for treatment? And I would like to address these questions today in my presentation. But we can also phrase it in other words. If a local treatment, for example, surgery, is considered an approach for oligometastatic pancreatic cancer, then it has to provide the following. It has to improve survival over and above what is achieved with systemic treatment. It should have no major morbidity and mortality, and it should have no negative impact on quality of life. Let's look at the data. First of all, the tumor biology. This is a paper from the Johns Hopkins, already published in 2012, where the group could show that even tumors that are deemed resectable 2 centimeters in diameter, as you see in the lower right corner, have a 60% probability of metastases at diagnosis. This means that even resectable pancreatic cancer has a very high likelihood of being metastatic in the first place, and not oligometastatic. And the problem is in metastases in pancreatic cancer, this is a systemic disease. And alas, in the majority of cases, not really a localized problem. And if there is something like oligometastatic disease in pancreatic cancer, the group is unlikely to be rather big. And we don't know the biology of this oligometastasis. The question is oligometastatic disease something we can really put together? Is this an entity on its own? When we look at the subgroup analysis, these are the forest plots from, first of all, the Prodigy study on the top and the mPAC study on the bottom. And you see we have, when you look at the number of metastatic sites and the number of metastases, whether we have 1, 2, or 3 metastatic sites, the outcome with FOLFIRINOX is fairly similar. The same is true for synchronous versus metachronous metastases. Also, pulmonary metastases or hepatic metastases do not differ with respect to responding to chemotherapy. In gemcitabine nab-paclitaxel, there seems to be a slightly better outcome when you have only one metastatic site. However, you see that there are very few patients having that, and you see that the confidence interval is rather large. So there is no major difference in benefit from chemotherapy with respect to the number of metastases. The other question is, what is oligometastatic disease in the first place? How is it defined, or how can it be defined? First of all, of course, we could define it by the number of metastases, but what is the right number? 1, 2, 3, 4 metastases? We could make it up to the size of metastases, 2 centimeters, 3 centimeters, 4 centimeters, or we could actually link it to surgical accessibility. There are papers reporting safely resectable metastases as good metastases that are really easy to use for a local approach. And of course, safely resectable means there should be no increase in morbidity and mortality when you resect these metastases. Do we make it depending on the localization? Maybe only liver, only lung, or lymph nodes? Does it matter whether it's a single metastasis in one organ or at multiple sites? And of course, we could make it due to the biology, synchronous, metachronous metastases, or only intraoperatively detected metastases. So there are lots of questions here. What are the answers? The Cologne group around Christiane Bruns proposed a definition of oligometastatic disease in pancreatic cancer. They examined 128 cases with M1 metastasis. 63%, which is quite a high figure, had only a single organ metastasis, abbreviated as SOM. The median overall survival in these patients with a single organ metastasis was 12.2 months as compared to 4.4 months with multiple organ metastases. As you see, this is not a particularly exciting figure, 12.2 months, when we compare it with the results from the clinical trials. They came up with a proposition that oligometastatic disease, OMD, should be considered when there is a single organ metastasis. The CA19-9 at baseline is less than 1,000. Patients should have responded to or should have at least stable disease to the first-line treatment. And applying these criteria, they could identify 8 patients with liver metastases and 2 patients with lung metastases that had median overall survival of 19.4 months as compared to the other group with 7.2 months. And they concluded that patients fulfilling these criteria might be eligible for surgery. However, this is a huge selection bias. These data have not been collected prospectively. And the question is also, what is the size of this group? When you consider that the original already selected group was 128 patients, you come up with around 8% of the large group has only of single patients with single organ metastases can be potentially eligible for surgery. So you actually it will be hard to find the patients that are really fitting into this group. The other question is, could we maybe identify patients easier and better by biomarkers? There is one paper showing that CA125 measured postoperatively can really discriminate um, between patients benefiting and not benefiting from surgery after survival. And it may differentiate the groups. The trouble is, it doesn't help you when you only evaluate postoperatively, because then you already had done surgery and you would like to decide upfront before you actually perform the procedure whether or not a patient will benefit or will not benefit. Because you see, the blue curve with reduced postoperative CA125 levels um, did not benefit, whereas those with the elevated postoperative CA125 levels did benefit, but you didn't know that up front. They started at the same level, which means CA125 is interesting but not useful as a preoperative marker. What about circulating tumor DNA? And as you know, circulating tumor DNA is a very interesting tool also in pancreatic cancer for assessing early relapse. And the frequency of mutated genes you can detect in the blood of patients with metastatic pancreatic cancer is actually quite high. You can detect particularly KRAS mutations and P53 mutations quite frequently, and also APC, FX, FBXW7, GNAS, ERP2, and so on. So this might be an interesting tool, and it's not so difficult anymore because there are, of course, commercial solutions available to detect mutated genes in ctDNA that will allow the detection and make it rather easy. And these are data from a recently published paper in PLOS ONE, and they show that patients, when you can detect ctDNA, and this is preoperatively in metastatic pancreatic cancer, you have a much worse outcome as compared to patients where there is no ctDNA detectable. The curves in the overall survival and progression-free survival with no ctDNA are in red. In blue, you see the curves where ctDNA was detectable. And when you then compare that in a hazard analysis for overall survival, univariate and multivariate, you see that the detection of ctDNA was in both analyses, univariate as well as multivariate analysis, the only statistically significant difference between the groups for overall survival, but also for progression-free survival. And the ctDNA negative is a prognostically good group in metastatic pancreatic cancer. So maybe ctDNA status should be part of an algorithm that leads us to a local treatment in metastatic disease or not. When we then say, okay, there might be biomarkers, we might be able to define a group, but what are the benchmarks? And the benchmark in metastatic disease has been set by the PRODIGE 11 group that showed that the combination of 5-FU, oxaliplatin, and irinotecan in the landmark PRODIGE 11 study improves median overall survival as compared to gemcitabine from 6.8 months to 11.1 months. Of course, these were patients with a good performance status, ECOG 0. But on the other hand, if you think about doing a multimodal treatment with a patient, these patients should at least be eligible for intensified chemotherapy. So I think this is the group we should use as a standard. And there is another benchmark. These data are from prospective randomized phase 3 trial. So these are not highly selected retrospective case series. This is quite important to remember when we compare data from different trials. And the second benchmark is locally advanced pancreatic cancer. And this is a oligo. This is about 25% of patients. And this is a small but significant group. And these are patients that in general remain locally advanced but don't get metastatic. And there is quite a lot of debate how you differentiate the locally advanced from the metastatic situation. But you see the FOLFIRINOX protocol shown on the upper right, 11.1 months. And when you employ the same protocol in locally advanced disease, you can actually increase the median overall survival up to 24.2 months. So this is something in between. When you employ multimodal treatment, you should end up between 11 and 24 months roundabout. I think this would be at least what you would expect when you employ additional treatment and, of course, employ an additional burden for the patient. Okay, so we have now the potential group, we have set the benchmarks, is the evidence that surgery improves survival in oligometastatic disease. This is a case series from Heidelberg University. You know, the department of Markus Büchler is a very large department with a high focus on pancreatic cancer, and they've done landmark work also with the SPAC studies and really pushed the field forwards. This is a retrospective analysis of 12 years of work with patients with 1 to 3 liver metastases. When you consider that this hospital does round about 400 to 500 Whipple procedures per year, I'm serious about that, then you see these are highly selected patients when it takes you 12 years to collect 128 patients with 1 to 3 liver metastases. They were either synchronous or metachronous. 85 were liver metastases, and 43 were patients with intra-autocaval lymph nodes. Morbidity was high, 45%, but mortality was low. This is a center of excellence with 2.9%, which is, of course, a very interesting figure. However, when you then see the median overall survival, this was 12.3 months, with a 5-year overall survival rate of 8% in case of liver metastases and 10.1% when you consider lymph node metastases. And the curves, you see them on the right, on the upper case for survival function, and the lower case as well. You see that this is not a particularly convincing result. When you think about that, conventional chemotherapy is 11.1 months, the locally advanced situation is 24 months. So the surgical procedure, although mortality was low but morbidity was high, doesn't really improve a lot with respect to median overall survival, at least in this case series. The question is this a signal for further trials? Maybe we should improve the trial design. Maybe we should improve the selection of patients. That, of course, could be an interesting option. And maybe it's also a matter how you actually include the centers. This is now not a single center analysis from Heidelberg. This is a multi-center analysis. 6 European centers, 69 patients in 20 years. So this is also a very highly selected group of patients. And the criteria here was safely resectable liver metastases. If you ask 10 surgeons what are safely resectable liver metastases, you might get different opinions. And I'm looking forward to discuss this issue tomorrow with a very renowned pancreatic surgeon, Massimo Falconi. And I'm very curious to hear his opinion about the definition of safely resectable liver metastases. And we had a simultaneous resection of synchronous liver metastases in this analysis. And the control group were patients with exploration only. However, this is not a good control group because these are patients usually that have a very advanced disease, and therefore you don't resect on them. This is patients where you try to see whether there is a resection possible with curative intent, but then you close the situs just because there is no chance. The majority, alas, didn't have pre-treatment and only post-operative chemotherapy. The median overall survival was 14 versus 8 months. They could show a benefit only in tumors of the pancreatic head, as you see on the lower left side. And the few patients that actually did get neoadjuvant chemotherapy did not benefit. But of course, that should not argue against chemotherapy, but that also only argues for appropriate neoadjuvant chemotherapy protocols. So taken together, this is also not a really exciting result with respect to overall survival. This is a considerable trauma to patients with respect to the surgery. And you see, although this was a very, very highly selected population of patients, 6 centers, 20 years, 69 patients. This is again to show that is only a benefit for patients in the pancreatic head, although small group of patients, and it's probably difficult to draw further conclusions from that. Another analysis pooled all the available evidence, and they found when you resect the primary plus liver metastases, so synchronous liver metastases, you get around 10.4 months average median overall survival. And these are the different papers in a time frame from 1996 until 2012. So this is, when you compare them to the 11.1 months with FOLFIRINOX in the systemic treatment, not convincing. This is an interesting thesis published in 2018 in the Netherlands. And this guy has taken the effort, Van der Veer, to really compile even more papers and be even more up to date. And what they can show is that there is a huge variation with respect to overall survival. They could show that the 5-year overall survival rate is up to 34%. The median overall survival is up to 25 months in case of synchronous and up to 31 months in case of metastases. But you see that there's a huge range with respect to overall survival. 1 year, 3 year, and 5 year. This is again depicted on the right side. What is suggested from these data is that metachronous resections might be more favorable than the synchronous ones. And my explanation is that this is most likely due to the case because you know the tumor biology already, and you don't know whether this is an a priori systemic metastatic disease or whether the metastases remain localized, at least for a certain period of time. So if you consider planning studies in patients with metastatic pancreatic cancer and localized treatment, I would always advise to do it in a metachronous setting and not in a synchronous setting, because you don't know the tumor biology in this case. Another study, this is a retrospective case control study in patients with a T3, N1, and M1 tumor with less than 2 metastatic lesions in the liver or the lung, and each less than 4 centimeters. Employed neoadjuvant chemotherapy with FOLFIRINOX or gemcitabine nab-paclitaxel. So this is sort of state of the art. What would you do now in a clinical prospective trial? This is only 6 patients, so very, very small trial, but it's the best you can come up with at this moment in time. They also allowed radiofrequency ablation, and the control was surgery alone in the M0 state or no surgery in the M1 situation. The problem was that the study was not well balanced, because in the chemotherapy alone group, CA99 levels were about 3 times as high as in the surgery group. So they did select the patients for surgery also according to CA99, which makes sense. And what they showed also is that ECOG matters, because those patients with a worse ECOG had also a worse survival. What it suggests is that the M1 surgery group that received neoadjuvant treatment fared at least as good as the M0 surgery group without neoadjuvant treatment, of course, because that's not a clinical standard. And the M1 no surgery group, alas, this was the group with the worst CA99, the higher CA99 levels, did not fare so well. So this, I think, is thought-provoking, but it doesn't prove, unfortunately, anything, because 6 patients in a retrospective analysis don't really give you a clue. It might give you something to think about. There is another recent survey comparing surgery as well as other local treatments in metastatic disease, in oligometastatic pancreatic cancer. And in this case, quite a few patients already received neoadjuvant treatment. You see the inclusion periods of these trials were rather long, sometimes up to more than 10 years, sometimes even longer, 20 years, like in the study of Tahasi. This is the one I already showed you. And when you take it together, there is a median overall survival between 9.1 and 18.2 months. In one study, it was 39 months. This was quite exceptional. And the recurrence rate, and this is quite important even after resection of the metastases, is 74 to 93%. This is pancreatic cancer. And even in oligometastatic disease, where you have a high chance, for example, in colorectal cancer, to really cure the patients or have at least a long remission-free interval, you have here quite early recurrence, and you have recurrence in virtually 3/4 to 100% of the patients. What about local regional treatment? This is also from the same study, and what you see is this has been TACE, RFA, SIRT, and radiotherapy. Again, you have quite a variety of overall survival times. Median overall survival was between 6 and 20 months. Also, not too bad for local treatment. And again, recurrence rates were between 80 and 90%. So there is also not a clear advantage, at least from what we can see, of a particular local modality, either being surgery or being other modalities like TACE, RFA, or SIRT for oligometastatic disease. The question also is, when we do a multimodal treatment, we also have to consider the side effects and the impact on quality of life of this multimodal treatment. And of course, I showed you that when you do a multimodal treatment, you employ the most efficacious chemotherapy. This is, at this moment in time, the FOLFIRINOX protocol, and because it has the highest rate also of tumor response. And when you look at the quality of life, you see that this protocol, interestingly, although it has more side effects, actually does delay the deterioration of quality of life as compared to gemcitabine. So patients get worse much later than when they just receive single agent treatment. So this is good news, and this is published. What about surgery now? What is quality of life after pancreatic surgery? And what you can see here, that the mental health summary score remains after surgery, and there is no difference between malignancy, benign tumors, or chronic pancreatitis. However, the physical health summary score is reduced in the first year after surgery, and it's at its lowest actually. The PTS score is at its lowest 24 months post-operatively. So there is a decrease from 43 to 34%, which needs to be considered when we think about the effect of a multimodal treatment. And this is another study, quality of life after pancreatic surgery, and this was a prospective longitudinal trial employing the RTC QLQ-C30 physical functioning, the RAND36 physical functioning, and the role restriction modules. And what you can see is that the quality of life after pancreatic resection deteriorates postoperatively, and it takes a while for complete restitution, which is only almost 6 months delay. So only after 6 months, and for some functions, the physical role restriction, in that case, it's even 12 months. It takes time after resection to really be back up to scratch. And when you then consider that median overall survival is 9 to 18 months, we have to balance the impairment in quality of life with the increase or the small increase in median overall survival. So when we consider multimodal treatment in oligometastatic pancreatic cancer, we really have to balance the benefit of survival with the potential effects on the quality of life. So oligometastatic disease is still an ill-defined entity in pancreatic cancer. We don't know about number and size of metastases that are ideal. We don't know about the role of extrahepatic metastases, for example, lymph node metastases, and we don't know whether synchronous and or metachronous metastases might be better. Obviously, metachronous metastases give us the advantage of learning a little bit more about the tumor biology. We don't also know whether intraoperatively detected metastases, being usually smaller because they're not detected by conventional imaging, might be better with respect, prognostically better than already preoperatively evident metastases. And the other question is, should we resect patients up front? Should we pre-treat all the patients? Or should we resect only patients that are stable under preoperative chemotherapy in case of visible metastases? And of course, which biomarkers should be used? And when we look at the data of surgical and other local treatments so far, we always have to consider that only highly selected patients have been included in this retrospective analysis. The survival is not really striking when you employ local treatment in addition to, sometimes even in addition to chemotherapy. The recurrence rate is really high, and quality of life, particularly after pancreatic surgery, can be seriously compromised. And we don't have any prospective data. in the group of patients that are not eligible for aggressive chemotherapy, we have no data whether resection or not is, or resection at all is a modality, because the studies already, the case series published only included patients that were really fit for surgery, also given the fact that surgery by itself has quite some side effects. So Niesen actually proposed an algorithm for multimodal treatment of oligometastatic disease. And in case of pancreatic cancer, check for oligometastatic disease. And if it's not a diffuse systemic spread or extrahepatic involvement, check the performance status and check whether metastases are potentially resectable. And if the performance status is good and they are potentially resectable, you should pre-treat the patients, and they recommend FOLFIRINOX or gemcitabine nab-paclitaxel as the most efficacious treatment regimens. Then look if there is no progression and still a good performance status. And if this is the case, and they propose factors like a more than 50% reduction CA19-9, one might also employ ctDNA, as I showed you previously. And then there might be a chance for surgical exploration. And if there is no progression, and in case there is no progression, there might be a chance of resection and of the metastatic disease. They also recommend resecting the primary. We don't know about that as well. We have no clue whether resecting the primary, which is of course the more aggressive approach, matters, because the question and the major question is, do we get the patient tumor free in this setting? The local treatment, if employed, is never alternatively to, but in this setting, always in combination with chemotherapy, and chemotherapy with proven efficacy, and not just chemotherapy anything. So when you have oligometastatic disease, what should be done? What would I recommend? I personally think we should examine multimodal treatments in oligometastatic disease, yes, but we should do appropriate, well-designed prospective trials. We should not do empathetic local treatment because the patient wants to get rid of the metastases, because I don't think we do the patient a favor. We need to define suitable subgroups, number, size, localization of metastases, and this has to be done in clinical trials. Maybe there are subgroups, biological subgroups, that fare better. When you think about BRCA1/2 germline mutated patients that respond so well to platinum-based agents, and maybe we can do a substantial decrease in tumor load and thereby open new avenues for localized treatment. Maybe patients with microsatellite unstable pancreatic cancer are also eligible for such a procedure after pretreatment with checkpoint inhibitors. We don't know, and it's a very small subgroup. We have to define the multimodal concept, the duration and the type of neoadjuvant treatment, also neoadjuvant radiochemotherapy maybe. And we also have to think about additive or maintenance strategies after surgery. We need to have biomarkers that we also prospectively evaluate to make sure that we're getting a safe and good biomarker to guide us. And we have to assess quality of life. However, before more data are available and outside of well-designed trials, I would vote with John Burko. The no's have it, unlock. And with that, I thank you very much for your attention, and I'm happy to take questions.
Thank you very much, Thomas, for this very excellent and brilliant overview about, I would say, still complicated topic. In the beginning, before we start our discussion, I would like to address now the definition of oligometastatic disease, who is liable for surgery, what is the daily clinical practice in the centers of our discussions. I would like to start first with Dr. Uesaka. In the Shizuoka Cancer Center, how is your approach? Who would you consider to be liable for secondary resection in the oligometastatic disease? How do you do that?
Yeah, I'm a surgeon, so I think the indication for surgery is very important. And from the surgical point of view, one of the important points is synchronous metastasis or metachronous metastasis, even if it is oligometastasis. If the patient has synchronous oligometastasis with primary cancer, I think nobody select the upfront surgery. Chemotherapy is, of course, very important, and of course, the favorable results, favorable effect of the chemotherapy is very, very important for the indication of surgery. But nobody knows the timing of the surgery or the indication, precise indication of surgery. In our institution, the indication of surgery is very strict. If the chemotherapy results in the normalization of CA19-9 level, or for at least 1 year, 12 months, we try to resect the tumor. That may be a very, very highly selected patients, but the survival after resection is very nice. So the indication is very important, and of course, to decide the indication, favorable results of the chemotherapy is very important, I think. For that
Thank you very
mean,
much.
the surgery, yes, for surgery is very, of course, important, but I think it's a adjuvant surgery, not the surgery is not the main point. Chemotherapy is main point, and it's the adjuvant surgery, I think.
Okay, I see. Thank you very much. Massimo, in Milan, how do you approach patients with oligometastatic disease?
Uesaka has just pointed out, surgery, if any, is just adjuvant to a very good, timely, sustained response to primary chemotherapy. And probably what I would like to add to the beautiful lecture of Thomas is just to say that probably lung metastasis may have a different behavior or different response in comparison to other side. So I would like also to the panel a point of view whether we should consider lung metastasis in a different way. Despite I completely agree with Professor Uesaka that primary approach should be always chemotherapy, if possible with high profile, and the response should be sustained over the time.
This is an important point, but can you tell me, Massimo, when I know from other tumor types where a liver metastasis resection is quite common, like for colon cancer, the liver surgeon always tell me if you do too long time systemic treatment, this causes liver tox, and so it makes it more difficult for resection. I know it's a difficult scenario if we talk about oligometastatic disease, it's less metastasis, probably atypic resection. But do you have any impact of this systemic treatment? Do you see an ideal time span of systemic treatment before you do liver surgery when it comes to liver metastasis?
Gerard, once again, your great experience pointed out perfectly what is the matter of concern in performing liver surgery after chemotherapy. Do not forget that, for example, in a metastatic setting in Italy, we do too much FOLFIRINOX as first line because we usually use Abraxane plus gemcitabine or PAX-G regimen as scheduled by Michele Reni. The reason is that Abraxane or nab-paclitaxel is allowed only in first line, whilst in second line we cannot use anymore. So some concerns which are related to the use of platinum compound on steatosis therapy, and then a more difficult surgical liver recovery after surgery, then it's probably not an issue here in Italy because of this first choice chemotherapy line. Second, if we are speaking about oligometastatic disease, extended liver surgery, we are speaking about to primary quite often, thanks to chemotherapy, liver metastasis has been already there. So probably the concern as regard chemotherapy, long-standing therapy, major liver surgery, it is not an issue. Last, I would like to expertise our protocol in very, very selected cases. Usually we perform 6-month chemotherapy. If we have, when you are dealing from the beginning with a lot of oligometastatic disease, chemotherapy for 6 months is marker and the morphological response is seen. Then we try to use some time radiochemotherapy on the primary just as a brief choice in order to be sure that systemic disease is under control, and thereafter we are moving to surgery.
Thank you very much. So may I ask Thomas, you had it in your slides, but for how many months do you think at minimum do you have to see a disease controlled by systemic treatment before considering an oligometastatic pancreatic cancer patient, before you refer this patient to the surgeon? So how many months do you like to see a disease control? Is it 3 months, 6 months, or even longer?
This is a very difficult question, Gerald, because we don't have any data that really will guide us. And the retrospective data has sometimes been obtained in patients that have been on treatment for a really long time, after sometimes 1 to 2 years. And this is very exceptional. And you already pointed out that, of course, we have a higher toxicity when we actually carry on with treatment for such a long time. So we will run in Germany, we will try to run a trial, but we will see how well it recruits. And the lead is Michael Gardimi and Jens Siewicke, where we try to pre-treat the patient at least for 6 months, 4 to 6 months, and see whether or not then, if the patient is stable after half a year of treatment, and this is intensified treatment with FOLFIRINOX, then with respect to size and numbers of metastases and locations of metastases, then surgery is tried under very, very defined conditions. So I would say half a year at least, but on the other hand, probably not much longer, because then you run into troubles with all the problems we see from liver surgery in colorectal cancer, as you already pointed out.
Dr. Uesaka, in your center, what is the minimum of systemic treatment you would like to see the patients on before you considering secondary resection?
If the patient has synchronous metastasis, at least 1 year. But if the patient has metachronous metastasis after initial resection, the story is completely different. Patient have pulmonary oligometastasis, pulmonary metachronous oligometastasis, especially the duration between the initial resection and recurrence is longer than 2 years. We select upfront surgery because the pulmonary metastasis is very the survival after resection is very nice. But even if the patient has metachronous metastasis, the liver metastasis, we select the chemotherapy first. We usually perform at least 1 year chemotherapy before surgery.
Okay, thank you so much. So let me bring us to the next question. Let's say the patient got a secondary resection, so after neoadjuvant or after systemic treatment. How important, and this is first question to you, Thomas, how important is the pathological regression grade for you for guiding and postoperative systemic treatment? So do you look at it at all, or do you say, no, I look on the radiological response, this is more important for me? So how important is for you pathological regression grade?
This is a very good question, Gerald. And first of all, the problem is we do not have any standardized regression grading in pancreatic cancer. This is something we're trying to somehow stratify for the primary now in the framework of our neoadjuvant trial in resectable tumors. Of course, we can deduct it from other trials. Personally, it's odd because when you don't have any regression at all, I would not use the same chemotherapy as I've been using in the first place, because it obviously wasn't efficacious, and I would change the chemotherapy, not knowing whether or not this would somehow make a difference. What we try to do to get out of this problem is that we do pharmacotyping in advance. So we're setting up from all patients, particularly in this group, we're generating tumor organoids, which is usually quite feasible because you get a good take rate when you biopsy the liver metastases. And we do pharmacotyping on these organoids, and we have a paper now submitted, a 95% concordance rate between response in the organoids and response in the tumor itself. So hopefully this might be a way to circumvent the problem, being always in hindsight looking at a tumor that has not benefited from chemotherapy, and maybe having a little advantage up front to do the right thing at the right time.
Thank you very much. Massimo, is it something you're interested in when you look at the histological report to see how good was the neoadjuvant systemic treatment?
And usually is a combination of many score, which consider many features, which consider morphological response, biomarkers response, if any, or if expressed. We are speaking above all in the routine practice about CI99, as well as the pathological response. And Gerard, sorry, if I can, I would like to ask to all of you, what is the proper diagnostic workup? Because one of the issues is that if you are looking for something in a proper way, you probably may detect more oligometastatic disease that nowadays are putting in upfront setting. And then probably to discuss about workup probably is an issue in this setting.
Yeah, absolutely. So Massimo, what is your workup? Is it PET-CT, MRI, all of those?
Sorry, now usually we proceed with CT scan, staging CT scan with chest and abdomen, and we are looking at the marker. If we have an elevation of CAE, then we move always by performing MRI with hepatospecific contrast medium. Otherwise, we stop our workup and then we move to neoadjuvant therapy. We look to the response rate, and then we move to surgery in case of stable disease in borderline or locally advanced one, as probably most of the surgeons all around the world used to do. However, in oligometastatic disease, we always check both the patient with CT scan, MRI with the hepatospecific contrast medium, as well as FDG, 18 FDG PET-CT.
Excellent. Dr. Uesaka, do you have an workup protocol for patients you're considering for secondary resection?
Our protocol is nearly the same. Routinely, we perform CT scan, and when we have to judge the operability of patients, we usually perform EOB MRI and also PET scan. So they're nearly the same.
And the biomarker CA99, do you look at it?
Of course, it's very, very important. As I said, when we decide the secondary resection, we check the CA99 level, and we decide to perform the surgery if the normalization of CA99 continued for a year.
Excellent. And Thomas, may I hand you over the question of Massimo?
Yeah. So what we do for work, our radiologists got a new toy to play with. So we got a PET MRI, and this is of course nice because you can combine and you see, even in case of fatty liver, you see the lesions, and you may be able to detect more metastases with the PET part of it. Of course, this is research. This is something we have to evaluate prospectively, and in these exceptional cases, this is something we do now prospectively to see whether it makes anything better over and above what we routinely do in these patients. But I would definitely do a PET CT, and we just updated our S3 pancreatic cancer guidelines, and we now followed the British guidelines from NICE and said we recommend, in case of resection of pancreatic cancer, we also recommend a PET CT anyway to really exclude liver metastases, and of course we will see that as well.
Okay. May I ask you, Thomas, as a medical oncologist, what do you do after resection? I mean, it's still considered to be a systemic disease, right? Even if you have resected the oligometastasis. What do you do then after resection? Do you continue with the very same protocol? Do you do a kind of a maintenance treatment? Do you stop any treatment? So what is your approach after
This is
resection?
also a very interesting question, Gerald. And I think at the moment, because outside of a clinical trial, we're talking about highly selected patients. And we had recently one patient where we did resect on the patient 2 years after starting chemotherapy on and off with maintenance treatment. And she had just 2 liver metastases left. And she was fed up of chemotherapy and said, okay, we tried, because she was stable on that, and we resected the metastases, and there was no vital tumor anymore. Of course, this is a patient I would not recommend carrying on with chemotherapy. If this is a patient with, let's say, half a year of intensified chemotherapy and still vital tumor, you really have to consider, and then something we make it also, as you said, regression grading, also CA19-9, we look for ctDNA in the blood, because these are very exceptional patients. This is not standard, and we don't have currently. We will have a protocol, but it's not actually in action right now. Then we will really make it an individual decision what would be best, and also taking into account the side effects in the patient's wish, toxicity of the previous treatment, just to make sure that we do not really interfere with quality of life so much that at the end the situation for the patient is not better than it has been prior to surgery.
Thank you. Massimo, is it an palliative surgical intervention, oligometastatic disease? Is it
For sure, Gerard. I think that in the presentation, Thomas was quite optimistic, saying that quite often they recur. We say they always recur. So quality of life is new. If we try a surgery in this specific setting, we should consider that we may at least free the patient from any therapy for at least a certain period of time. Because if we are forced, as regard your previous question to Thomas, if we are forced to continue therapy, it means that we fail in putting the indication.
okay? So you're more for stopping systemic treatment and do very tight follow-ups, or do you recommend follow-up scans?
Yes, for sure, obviously. Sorry, I don't know whether if we have additional weapon, I think that we must follow up also this patient. If we think that we have already exhausted all the option, probably does not make any sense. But the patient that has suffered, I would say, this way, probably won't accept to not be followed up anymore.
Thank you. Dr. Uesaka, some words from your side. You consider also oligometastatic disease if patients, this very pre-selected subgroup of patients who might have a benefit of secondary resection as a palliative resection? And if yes, what is your approach considering post-operatively systemic treatment?
Yeah. Even after complete resection for oligometastatic disease, we routinely perform the adjuvant chemotherapy at least 6 months, but if possible, more than 1 year. because even if it is oligo, but still it is already metastatic disease. That means a systemic disease. So even after local resection, we continue to perform chemotherapy. The regimen for chemotherapy is the same as the adjuvant chemotherapy.
Absolutely. Thank you so much. So we are almost at the end of this symposium today. So is there any question you want to discuss with us? Is there anything left? Massimo, Thomas, Dr. Uesaka?
Just to say a tenant, I think that we would like to look for evidence-based medicine as probably the Thomas suggested trial would like to reach, to get. However, I think that in this setting, we should remain really in a targeted or individual way of approach because of low numbers, because of very highly selected cases, because of the expertise of the center. So I think that we are remaining more artisan rather than evidence-based doctors. Sorry, this is my personal feeling, because there are so many aspects to be considered that it's difficult to put all together in a trial.
Yeah, absolutely. So I totally agree with you. Thomas, do you have some final comments?
Yeah, I think I always think of surgeons as artisans. To be honest, this is an art. There's no doubt about that. The reason why I think a trial would be interesting is to see whether or not the trial can be done. So, can the patients be recruited? Will we find criteria that really enable recruitment in the first place, that we can somehow define the population? And we might fail on that. But I think it's worth a trial just to show that you cannot run a trial. Even that would be, I think, quite sensible to define areas where evidence-based medicine comes to its limits. So I think this is one of the goals of the trial, but otherwise I completely agree with Massimo.
Dr. Uesaka, some final
Yes.
comments from your side?
Yeah. Even the metastasis is oligo, as I said, it is already systemic. It is a metastatic disease. So I'm a surgeon, but the important point for surgery is the favorable response to chemotherapy. That's a very important. Surgery is an adjuvant role of the treatment.
Yeah, absolutely. Thank you so much. I think it was really a very fruitful and great discussion we had today, and want to close this session. It was a big pleasure to have these highly international recognized experts with me today, and I hope for the audience also you could enjoy this symposium of the Pancreas Cancer Academy. Have a good day. Stay safe. Thank you so much. And I hope I will see you the next session on the Pancreas Cancer Academy. Bye-bye.
Bye-bye.
Thank you.
Thank you.
Bye-bye.
Bye-bye.